Hey Raymond,
Hi,
how are you doing?
I'm good, and you?
I am doing well. Looks like it's just me and you today.
Yeah, you know how the situation is now. People are very busy. I feel I'm even at work. Yeah, it's not easy.
That's okay.
All this.
So you are currently at work right now?
Mm-hmm.
Okay.
Yeah, I'll be getting off at 11.
At 11 p.m. Oof, that's gonna be tough. I think
Yeah.
what I'm just gonna I think what I'm going to do is I'll just wait for the next I'll say the next 10 minutes. If nobody joins, then
Mm-hmm.
I'll just make the recording, and you don't have to participate if you're busy. I'll just make the recording, and everybody can then watch it from there.
Okay.
Yeah. So let's just hang out for another 10 minutes or so and see.
Yeah. I wanted to ask you this question on this.
Yes.
I wanted to ask you. 1 minute. Let me see if I can find the paper. I wanted to ask you. Um. Uh. hmm, what's the difference between because this it kind of like similar of
Mhm.
durable power of attorney and advanced directives and resident representative.
So advance directive is more like the resident si- so with advanced directive, the resident actually makes the option and says that, okay, for example, I don't want to be intubated if I cannot breathe.
Mm-hmm.
Doctor has to sign it, and the resident signs it. If the resident if the resident has like somebody that's like their legal representative or their legal guardian, the legal person can then sign it in the place of the resident. So with the advanced care directive, it's like an order for things like I don't want to be intubated if I cannot breathe. I don't want heart chest compressions if my heart stops. With durable power of attorney, it's more like you've given, one somebody, whether it's your son or your daughter, the authority that if I get to a point where I cannot make my own decisions just because of mentally or I'm just not capable enough, that person is the one that has to make those decisions. So when you work in a long-term care, you're going to see some residents that maybe their friend out in the community is their power of attorney, or their first son, or their last daughter, or their ex-wife. If the doctor wants to do something, now you have to contact that person first, like, hey, can we do this in terms of treatment? Can we go this kind of medication? Can we? So, durable power of attorney, that's the legal person that makes decisions for that for the patient.
I mean, if I get you correctly, the durable power of attorney is when the resident can make decision for himself. That's
Yes,
when it comes into play.
yes. When the resident is not capable enough to make reasonable decisions, or yeah, is not capable to make reasonable decisions.
So
Some.
when
Mhm.
Mhm. So when the resident is okay, the durable the durable power of attorney cannot manifest.
No, if the resident has not officially signed over their right to that person, or If the court or whatever has not determined that this person needs to have a durable power of attorney, the resident still makes their own decision by themselves. So you have residents that they are the ones responsible for their own decisions.
So once the resident give the go ahead, that
Mhm.
person as from that time is responsible for everything for the resident
It's responsible for making every
decision.
decision. Yes, when it comes to like medical and all that kind of stuff, the person has to. You can only so, for example, if the doctor comes in and let's say there's a document, mind you, all of this has to be a signed document. It can't just be word of mouth. It has to be a signed document. So if a doctor comes and be like, this thing that's going on with your stomach, I think it's better we do like surgery.
Mm-hmm.
And the power of attorney comes and be like, no, I don't think surgery is appropriate. Let's try and do medication. Now, that's the route that the doctor has to go. If the doctor wants to go against that, it has to be now a whole nother legal gymnastic, trying to get authorization, whether it's from the court or from wherever, so that the doctor has to prove why that procedure is more important in order to do it above the authority of the power of attorney.
So um, advance directives um is a is a deci- is a it's a decision already made by the resident that in case of anything like this, people should not do this to me.
Yes. And most of the time, the residents don't just make that kind of decision on their own. Like they will sit with their kids, you know, most of the time they will be with their kids and be like, you know what, I really I don't want to do this. I don't want to do it like that. I don't want it like that. They kind of deliberate. But as soon as the resident signs it, that this is what I want, because you have to understand a lot of them are vulnerable people, some of them don't know any better.
Mm-hmm.
So as long as it's been signed and the doctor comes and sign it, like this is your advanced care directive. You don't want this procedure if you need this. You don't want this one. You don't want this one. That's how it is. It has to go like that. So in every patient's chart, because they'll always have chart in their chart, you always see those forms in there. Who the power of attorney is, who if the patient wants uh advanced care directive for do not resuscitate, do not intubate, all that kind of stuff. You see it on there.
Yeah. And what about resident representative?
The resident representative is usually what they call the ombudsman, and that one is it's a whole
Ombuds Ombudsman.
yes.
Mm-hmm.
Like the ombudsman is it's like a legal representative for the resident. So usually that one is like an outside person that comes into the facility and talks with like the residents, and they're like a legal advocate for residents.
Mm-hmm.
And if a resident is having problems with the management, for example, the management in the in the facility, the ombudsman is
Mm-hmm.
like the middleman that tries to sort out all those differences.
Okay, the resident is having issues in the facility.
Like, yeah, like okay, when I say issues with the
I mean,
facility,
it means the ombudsman is like a mediator
it's like a
between
mediate
between
between
the resident and the rest of the facility.
yes, but his main objective is for the interest of the resident. He doesn't have the interest of the facility.
Mm-hmm. Is to
Yes.
make sure that the interest of the resident is being met.
Yes.
Mm. Before I used to think that before I used to think that the ombudsman is like the person that buy groceries and bring that meets the needs of the what is needed in the facility, like like in this some of these assisted living homes, like going for errands, bringing groceries, running
Mm,
the affairs of the. That's what I used to think about
no,
ombudsman.
no, no. Ombudsman doesn't do that. Ombudsman is just like the it's an advocate.
Yeah.
People that fight for
Mm-hmm.
the right of the residents. That's and whatever that's as far as I know to buy
Groceries
food
are.
for the residents.
Uh, I thought maybe there's a name to call that one. There's no name for that
Sorry,
one, that kind of person.
I can't hear you.
I said there's no name for that kind of person. Is there any name for someone that runs errands for the facility? Is there any
Uh,
name for someone that runs errands for the facility?
so which is part of what we're gonna do today, or maybe tomorrow. The facility has like a kitchen department or whatever like that. That they you
Mm-hmm.
have like a whole manager for dietary that buys the food. So they have
Mm-hmm.
so so in a long-term care, they have dietary department. They have housekeeping that cleans up the bed, disinfect everything when people discharge or leave. The dietary, they are responsible for buying the food, storing the food in the kitchen in their facility. They cook every day. You know,
Mm-hmm.
when things are running short, the dietary manager just pretty much knows what's running out, and then he goes and order them and buy them, all that kind of stuff. That's a whole department in the facility.
I went to I've not really had enough time from the last meet. I've not really had enough time to read because when your brain is tired, you cannot read.
I
Yeah,
understand.
but these ones are some things which I had from the last time which I had read. So when I saw this one, it said it's not appropriate for a nursing assistant to perform sterile procedure. What is sterile procedure?
So sterile in medical means that there is no uh, bacteria.
Mm-hmm.
So when they talk about sterile procedures, it has to do with things that you do on the patient that prevents bacteria from getting into the patient. For example, if you have to do what they call catheter change, you know what a catheter is, right?
I don't know what the catheter is.
Okay. So people that cannot pee, there are some people that they get problems with their urinary system and they cannot pee.
Mm-hmm.
And you have to either do what they call a straight catheter. Let me let me share my screen for a second and then I can that way I'm talking and you can see it. If I show you, it will make more sense if I'm telling you and show you. Okay. So you have what they call urinary catheter. That's an example. And what with a urinary system and they cannot pee. If it's a male, they'll put a tube in the penis. They literally insert it in the penis and it goes inside until it reaches inside their bladder. And the bladder is where you store urine. So that procedure of putting that catheter, it has to be sterile. And sterile means no bacteria, nothing, no infectious agent.
Wait, you put a tube into the penis, the tip that tube of the penis.
Yes. So the tube goes
Wait,
inside.
that tip where the urine comes out from, that's where you insert the tube.
Yes.
Wow.
So if you look at this one here like this, look at this picture here. That's an example of a person's
Mm-hmm.
penis. You see the
Yeah.
tube? Yeah. So the tube goes in there, but it has to be a sterile procedure because if you don't make sure that there is no bacteria, you will take bacteria from outside as you're putting the tube, you put bacteria inside the person's bladder. And the bladder is a sterile environment. So
Mm-hmm.
inside your body, a lot of the places inside your body is supposed to be sterile. The only
Okay.
the only places in the body that is not sterile is like your like in your mouth. Your mouth is not sterile. Your anal region is not sterile. The outside part of your private area, it is not sterile. But when you go inside, it's supposed to be sterile. And if you don't practice a sterile procedure, you're gonna get the person infected. So it is the responsibility of the nurses and the doctors, not the nursing assistant. So as a nursing assistant, you don't do sterile procedures.
Okay. So sterile, in other words, sterile is like making sure the catheter is actually disinfected. There's
Yes,
no bacteria in it.
yes. That is
Mm-hmm.
just one example of sterile. Sterile means
Okay.
there should be no bacteria. That's just what sterile means.
Okay. Making
Yes,
sure there's no bacteria.
yes. And it is not within the scope of the nursing assistant to be ensuring sterile. You can assist in the procedure. The nurse can tell you, I need you to do like this, I need you to do like this, but it is the responsibility of the nurse, not you as the nursing assistant, because you haven't been trained on those kind of procedures.
Yeah. So, what's another example for sterile procedure?
Another example for sterile procedure is um, there are some IV lines. So there's one. Okay. So if you look here, this is an IV line that goes in the person's hand. You see it?
Mm-hmm.
This goes directly into their vein. And because it's going in your vein, which is your bloodstream, which goes into your heart, it is supposed to be sterile. So when they are doing the change, either they are putting this tube in or they are just trying to clean up the dressing that holds the tube inside, it has to be sterile. And because if you make a mistake, bacteria is going to go into the person's
Blood,
inside the person's body, inside the
bloodstream.
blood, go to the heart, and that's going to be bloodstream. So this has to be another sterile procedure.
Okay. IV line.
Not this is not a regular IV line. This is like a PIC line, but yes, yes, IV line. But this is a PIC line, and with the PIC line, the problem is it just goes like straight into your heart. With this one, it goes straight into your heart. With with the regular lines, it takes time for the blood to travel and stuff like that. They 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 the catheter itself is always a sterile catheter, and you don't play with it. I'm talking about like the ones that
Wait, catheter, it means if I understand you correctly, catheter is something like a tube that directs channel something or it's a channel for something to go out of the body.
you have the idea right. Yes. So catheter pretty much it's like a tube with a hole in it. You can have an IV catheter, you can have a urine catheter.
Mhm. So now the catheter that is like a channel for the urine to leave the body. It goes into a sac that is being emptied or what?
Yes. Yes. So
Oh,
there is a sac in the outside. While the catheter goes until it reaches into the bladder, there is a sac in the outside that the urine just flows out and goes inside the sac. And
mhm.
the sac doesn't need to be sterile because the sac is way out there. It's not
Yeah.
inside. So you do a clean procedure for messing around with the sac, draining it and cleaning it. It's a clean procedure. Doesn't have to be a sterile procedure. That one is within your scope as a nursing assistant to always cleanly empty the sac.
Okay. So it means the sac will be kind of removed from the catheter and go and it will be emptied in the toilet.
Yeah, so there are things that we call uh, graduates. Graduates are just simply a container that has labels on it. It has labels on it where you can tell this is 1 liter, 2 liter, 500 centiliter,
Hmm.
and let me look for. So you'll find things like this. We call them graduate. You
Hmm.
see it? So when you go to empty the urine from the bag or the sack, you can see how many milliliters or how many liters is it. And then that way you go and you record it. Immediately you're done, you go and you chat it. They call it chatting. You go and put it in the computer, or if it's in a book, you write it down. That this person they had 1 liter at 1 o'clock. At 7 p.m. they had 500, milliliters and stuff like that.
Okay. So also they said it's not appropriate for NA to give medication, but I realize that in the assisted living, I don't know, assisted living where I work, I give medication. So I don't know the kind of giving medication they are talking about in this situation.
So in the assisted living where you work, do you work there as some kind of are you trained on medications?
No, I'm not checked on medication. The nurse, it kind of put the medication in it's like in the box where I like tear it up and just give it to the resident.
So, so if the facility has given you, normally you should not give medication without training. That's number one. That's
Yeah.
you should never be giving medications without any kind of training for medication. It's not your scope of practice. However, that is something that if the facility knows and they are okay with you giving medication and it's part of some kind of your job description, then that's a whole different case. But under normal circumstances, you shouldn't be giving medication if you don't have the training, either as a CMA. You could get training as a CMA or something. I know in a group home, if you work in a group home before you give medication, they even still train you, give you some kind of training before you give medication in a group home. So it is very risky for the nurse to just be like, give this to this person, give this to this person, because you have no idea what you're giving. You know what I mean?
Yeah.
You have no idea what you're giving. So it's worth you making sure that the facility is okay with you doing that, because I, what I'll tell you is if something goes wrong and you give that medication, you are responsible. You understand what I mean? Because you gave the medication. They the nurse could simply say like, "Hey, this is not what I gave him to give. How are you going to prove it?" So in the hospital or in medical practice as a whole, even us nurses, we are trained that if I go and I take Tylenol and I come and I give you Tylenol, like, hey, take this Tylenol and go give to my patient, you're supposed to refuse because you're not the one that went and pulled that Tylenol from the medication cabinet. So how sure are you 100% that this is Tylenol? You understand what I'm saying?
Mm-hmm.
Because the thing is, when it gets in the face of the law, when you are faced with a lawsuit and you are named in it, nobody's going to stand and be like, oh, I am the one that is responsible. Everybody just, it's going to be your problem because nobody can literally defend you for making such a mistake, especially if it's not within your scope of practice. Any other questions before we dive into the class of today?
Mm, It's not it's not appropriate for NA to take doctor's order.
No, you cannot do that either. It's not your responsibility. You should not do that. You've not been trained on that.
Yeah, we are good.
Okay.
Go. We're good. Go ahead.
All right. So say how you doing?
I'm fine. I'm fine. I'm at work. That's why I can't participate.
That's all right. That's all right.
Yeah, yeah.
Jacqueline, how are you? Jacqueline, are you there? Okay. All right. So today we're talking about basic nursing skills. So these are some of the things that are within your scope of practice as a nursing assistant. The very first thing on our list is monitoring vital signs. Vital signs are just pretty much parameters that indicate how your body is working. That's really what vital signs are. So monitoring vital signs is within the scope of nursing assistants. Vital signs are very important because they show how well the vital organs of your body work. If you have a piece of paper or anywhere you could write this down, I want to explain a little bit of something. Um, so as you see the human body, the most you have what they call the cells. That's the most basic part of your human body. You have cells. A combination of cells makes what we call tissue. A combination of tissues is going to make what we call an organ. And a combination of organs are what actually makes up your entire body. So if you peel out your skin, if you like go and scratch your skin and peel it off, those are skin cells. Those are cells that you're scratching off of your skin. A bunch of those skin cells together makes tissue. Now, a combination of so many tissues, it's going to make your skin, which is an organ of its own. Same thing. Your heart is made of the basic one, the smallest one is the cells. A combination of those cells, they make your heart tissue. A combination of tissues now makes the heart as an organ. So the heart is one of the vital organs of the body. Your lungs is an organ. It's a vital organ of the body. Your brain, it's an organ of the body. So you always hear about cells, which are like the smallest part. Then it goes to tissue. From tissues, now it goes to an organ. And a combination of organs make the entire body system. So you have like your brain working together with your heart, working together with your lungs. So I just wanted you guys to have that idea in the back of your mind. So monitoring vital signs consists of measuring your body temperature, counting your pulse rate, counting your respiration, and measuring your blood pressure. Pulse rate and heart rate is always used interchangeably. So you're going to hear one time they say pulse rate, one time they say heart rate. It's pretty much the same thing. It's just measuring how many times your heart is beating in 1 minute. So another thing to take note is in healthcare and medicine as a whole, they always count things per minute. They'll count respiration per minute. They'll count heartbeat per minute. They'll count, so respiration, heartbeat, all of that, they do it per minute. Nursing assistant cannot diagnose, but report changes in observation to the nurse. So diagnosis is not within your scope as a nursing assistant. As a nurse, there are something that they call nursing diagnosis. So a nurse can give what they call nursing diagnosis. You can say a patient is having pain from this. It's a nursing diagnosis. You can diagnose a patient with anxiety as a nursing diagnosis, but there have to be a criteria for that. As a CNA, you cannot document and say that this patient is having anxiety or this. You can simply document that the patient is reporting to you that they are having anxiety. You understand what I mean? It's good to know these things just because you probably will not have to worry about it. But the thing is, you want to be careful with your documentation and things like this, because whenever it gets down to the point where it's like in a lawsuit, it's like they could accuse you for diagnosing when it's not within your scope. So always report objective things. Report it as you observe it. If the patient is panicking, say that they are panicking. If they are shaking, say they are shaking. You might know that it's anxiety, but you cannot diagnose them with anxiety. So you want to always report the following. Resident has a fever that is outside the normal range or outside the resident's baseline. We talked about baseline a lot yesterday, which we said a resident's baseline is like what the normally is the normal range for that resident. So for example, if a resident, you go to count their respiration per minute and it's always been 14, 15 every time you go to check. And then all of a sudden you go and check, it is 9. That is outside the baseline of that resident. You have to report that immediately. Even if the outside baseline is still within the normal range. So I'll give you another example. A normal heart rate is between 60 and 100. That's how many times a healthy person's heart should beat within 1 minute, 60 times to 100. If you have a resident that you've been checking their heart rate, it's always 60 to 65, 60 to 65. Every time you go to check, it's within that range. And all of a sudden you go and check, it's like 92, 89, 92. That is still within the normal range for heart rate, but it is not within that resident's baseline. So that becomes a concern. So you want to report that. Are you guys following? Okay.
Yeah.
Awesome. So you want to you want to report fever that is outside the normal range, respiration or pulse rate that is too rapid or too slow. When we say tachy, what do you understand by tachy?
Tachy is too fast.
Yes. So if a resident has a heart rate that is tachycardia, if it's high, it means that it's tachycardia. If it's low, it's bradycardia. So tachy means it's going fast. Brady means it's going slow. So you want to report tachycardia, you want to report bradycardia. You want to report tachypnea. That PNEA at the end is referring to respiration. So if they say tachypnea, it means respiration is going fast. If they say bradypnea, it means that the respiration is going slower than usual. So you want to always report that. And then you also want to report changes in blood pressure. If they say, if you know that tension refers to blood pressure. If they say the person has hypotension, what do you understand by hypotension? Okay.
Low blood pressure.
Yes, low blood pressure. So hypo is low. Anytime you hear hypo in medical, know that they're talking about low. Your mind should automatically go to low. If they say hyper, it means that it's going up. So hypotension, low blood pressure. Hypertension, low blood pressure. The key thing to always remember here is patient's baseline. If you know your patient's baseline, sometimes what you do, so the first thing I always do when I work, in healthcare is whenever I go and I check a patient's vital sign, if it's hypo or if it's low, I go and try to look at the past record and see what their baseline has been. So it gives me an idea if this is within their baseline or if it's not within their baseline. So you want to be able to know the patient's baseline. But any concern that you have, always report it to your nurse. Any questions about all of that?
No, for now.
Okay. So if you guys want to take a screenshot for this says ranges. This is a vital signs ranges for adults. If you want to take a little screenshot or a picture, whichever one you can, it's important to have an idea about what it should be. So for temperature, as we are going to go further in this topic, you're going to realize that there are different places where you could measure temperature. You could do it in the mouth, which is what they call oral. Oral is the mouth. Rectal is the anus. You can get a temperature from there. You have the axillary. Axillary, that's your armpit area. So a lot of times in medicine or in healthcare, they're going to talk about axillary region, axillary section. They're talking about an armpit. Anytime you hear axillary, it's armpit. So you can take a temperature in the axillary region. You can also do what they call temporal. You can measure the temperature in the temporal region. That's the most common place where they do temperature, the temporal. And the way you remember that is like your temple of your head, the temple of your head. It's like an artery that is just below your the skin on your forehead that moves, that moves this way. So they always check temporal temperature. They always do it. They slide it on the forehead. They just put the thermometer here and slide it across. So again, you have the oral that goes in the mouth, the rectal that goes in the rectum or the anus. You have axillary. You have temporal, the one that goes on the forehead. And then you have the ear. The ear is called tympanic. So anytime you hear in medical, tympanic is referring to the ear. You're going to hear about tympanic membrane, membranes in your ear. So look at those vitals. If you can study them, that's great. Key thing to also remember is the most reliable place to get a temperature. The most reliable reading for your temperature is the rectal. It's the one from the rectum. It gives you a clear indication of how the inside body temperature is. But you're probably not going to be doing that one ever, because you're not going to go bend over your residents and be like, hey, come, let me check your temperature from your rectum. So, but just know that that's the most reliable. And then for the pulse or the heart rate, the normal range for an adult is 60 to 100 beats a minute. So your heart, a healthy person, their heart beats 60 to 100 times a minute. People that are athletes that do a lot of exercise, they run, you can see them. Sometimes their heart rate is less than 60. They go as low as 52. I've seen people in the 50s, and they are very strong and very healthy. So a little bit of information. When they always tell people about exercise, diet and exercise and stuff like that, your heart is made up of muscles, just like how your arms are made of muscles. If you go to the gym and you lift up weights or you squat, you build muscles in those parts of your body. It's the same thing with your heart. When you are very athletic and you're doing a lot of cardiovascular exercises, you're doing cardiovascular exercises, those are exercises that will make your heart to be, pumping. So if you do a lot of those, the muscles of your heart get trained also. That's why it's always important to do exercise. Blood pressure. You have the normal range for the systolic blood pressure is between 90 to 119. Diastolic is 60 to 79. For someone to be considered having hypotensive or low blood pressure, the systolic has to be below 90 and the diastolic below 60. For elevated blood pressure, their systolic has to be above 120 and diastolic less than 80. Then you have what they call stage 1 hypertension. Systolic 130 to 139, diastolic 80 to 89. Stage 2, systolic over 140 and diastolic over 90. Hypertensive crisis. When you get a blood pressure that's like 180 over 120, that is, you wanna take an Uber or a taxi to run and go tell the nurse about this. When people have this kind of high blood pressure, that's how easy it is for them to start getting strokes. Remember, we had talked about hemorrhagic stroke, or you have a hemorrhagic, which is the one that you have like a bleeding, and then you have the one that is a blockage. So when people have such a high blood pressure of above 180, there's a high chance that the force of the blood running could cause the blood vessel to rupture, and they can have a stroke and die. So hypertensive crisis is like a medical emergency. Always remember that whenever you're doing vitals, you want to provide privacy for your residents. You want to close the door. If they're sharing rooms, you want to provide like shades. If you're going to be talking about the numbers of the vitals, be careful how you're saying it so other people don't hear, or unless they are comfortable, because that's another thing. You have residents that will be asking you about other residents. You cannot tell another resident's medical situation to another resident. But if the resident want to share their information themselves with their peers, that's different. So always be careful about things like that. Guidelines for measuring body temperature. Body temperature reflects balance between heat created in the body and heat lost to the environment. Factors affecting body temperature include age, illness, stress, environment, exercise, and the circadian rhythm. So with illness, when people are sick, their body temperature tends to go up. And when people have an infection, their body temperature goes up. When you exercise, your body temperature goes up. Like you're running up and down, your body temperature is going to go up because your heart is beating faster. and we have what we call the circadian rhythm. So the circadian rhythm is like a cycle, the 24-hour cycle from you get up, you walk around, you do stuff, you go back, you lay down. You get up, you walk around, you do your activities, you go lay down and sleep. During that 24-hour period, different things happen in your body, and so it affects your temperature. When you're laying and sleeping, your body temperature is lower than when you're up laughing or you're up cooking or you're up eating. So that's just a little how the circadian rhythm can affect your body temperature. The different sites for measuring temperature, we went over this already, include the mouth, which is oral, the armpit, which is axillary, the ear, tympanic, the temporal artery, which is artery under the skin of the forehead. Those are the different sites where you can measure body temperature. And remember, the most reliable one is rectal, is the temperature in the anus. Though it's not the most common, but it's the most reliable. We have different types of thermometers. You have digital, electronic, tympanic, temporal, and mercury-free thermometer. I will encourage you guys to just look up whenever you get time the different types of thermometer: digital, electronic, tympanic, temporal, and mercury-free. Just look it up. I remember when I used to grow up back in Africa, we used to have the one that has mercury where you have to. Did anybody ever use that kind of a thermometer where you shake it like this? No? Some thermometers are color coded.
Yeah, every night.
So when you see thermometers that are color coded, red is for rectal, and then green and blue are for oral.
He takes it with animals really better.
So while we said that the most accurate temperature is the rectal temperature, the least accurate temperature is axillary temperature, the one you do on your armpit. That one gives you the least accurate results.
You basically can find allergic reactions of severe. Tell your doctor right away if you have rash, chest pain, loosening shortness.
Jenny, can you mute your microphone?
Tell your doctor about new pain or parasitic infection. Don't change your stop asthma medicines, including steroids.
Thank you. These are some scenarios where you should never do an oral temperature on a patient. So if a patient is unconscious, you don't do oral temperature. If they have had a recent oral or facial surgery, you don't do an oral temperature. Younger than 5 years, you don't do oral temperature. If they're confused or they're disoriented, no oral. If they're heavily sedated. So sedation, it's like people losing their consciousness. There are medications that they give people when you want to undergo a procedure. That medication that they give you and you go to sleep or you lose your consciousness, that process is called sedation. So if somebody is heavily sedated, you don't put things in their mouth. So you don't try to do an oral temperature. People that have seizures or they are likely to have a seizure, if somebody is having a seizure, you don't do oral temperature. If they are coughing.
What is seizures?
So seizure is what they call a fainting fit, where people fall and they're shaking, like it's involuntary movement of their body. Have you ever seen somebody falls and they're shaking? Sometimes foam is coming out of their mouth and their body is just shaking.
Yes.
That's what they call in medical terms seizures. So when people are having seizures, you don't check their temperature in the mouth. If they are coughing, if they're having facial paralysis. Remember, we talked about facial paralysis that could happen when you have a stroke. So you avoid doing oral temperature if their face is paralyzed, because they will not be able to close their mouth. In order to do oral temperature, the resident has to, when you put in the probe, the resident has to close their mouth and make it seal and put a tight seal. So if they're having facial paralysis, they cannot close their mouth. So you will not get an accurate reading. If the patient has an NG tube, yesterday we were talking about medical terminology. When we said nasal, what does it refer to when you hear nasal? Anybody? Nasal refers to the nose. When you hear gastric, what does gastric refer to?
Gastric neck.
No, gastric refers to the stomach.
Okay.
So gastric always refers to the stomach. When you hear gastric, it refers to the stomach. When you hear nasal, it refers to the nose. So you have patients or residents that they have problems swallowing. So they have to have an NG tube, which is a nasal gastric tube. It's a nasal gastric tube. So it goes into their nose, goes to the back of their throat, and then ends up in their stomach. That's how they feed them. So when residents have those kind of tube, you don't do the temperature in their mouth. If they're having sores in their mouth or they're having swelling in their mouth, you don't do oral temperature. Rectal temperature can be necessary for residents who are unconscious, residents who have missing teeth or dentures that do not fit properly, or residents that have difficulty breathing through their nose. I would like you guys to review and just do your own research and bring out the steps on how to do like temperature, checking temperature orally or in the ear or rectal. You could just do your research and just write it down, and then we could take a look at it tomorrow. Guidelines for measuring pulse and respiration. So pulse is the number of heartbeats per minute. Pulse is always used interchangeably with heart rate. The beats are felt through an artery as blood moves while the heart is pumping. In the human body, you have your heart in your chest. You have what you call arteries. Arteries, they pump blood from your heart to your body. That's what arteries do. Veins pump blood to your heart. They take blood back to your heart. Veins are closer to the surface of your body, while arteries are deeper inside your tissue. That's why when you look at your hand, you can see your veins sometimes. Like after an exercise, you could see veins. So the most common used pulse site is the wrist. And that one, they call it radial. So your wrist is the most common used pulse site. Blood pressure is measured in the radial and brachial arteries. I'm going to show you guys a little diagram here. Are you guys able to see the picture on the left, which says common pulse sites? Okay, so if you look, these are the different areas where you could measure pulse. These are the different areas where you could measure pulse. So you have the temporal, the carotid, which I had explained that the carotid is much more reliable if you're going to check on an unconscious person. You want to do the carotid. You have apical. Apical means that it's right at the level of your heart. You can do apical there. You have brachial. Brachial is right in your arm, like around your biceps area. That's the brachial. Radial is in the wrist. So typically to check blood pressure, they're going to do the brachial, which is in your arm, and they're going to do the radial. Those are the two common sites where they do blood pressure checks. You also have your femoral pulse, which is like inside your femur, inside your legs, in your groin area. You have popliteal, which is like behind your knee. You have the pedal pulse. Pedal pulse is like on the floor of your foot. And it's also referred to as dorsalis pedis. So these are the common pulse sites. Just remember the two most used for blood pressure is brachial and radial. Okay, I'll move back up here. Normal pulse rate for adults is 60 to 100 beats per minute. Pulse can be affected by fear, anger, heat, infection, exercise, pain, and medication. If a person is exercising, what do you think, which direction do you think their heart is gonna go? Is it gonna go tachycardic or is it gonna go bradycardic? Anybody there? All right, I guess I'll just proceed and then let me check the chart. Okay, awesome. Yes, it's gonna go tachycardic. Great job, Sose. So when a person is afraid, it's the same thing. Your heart beats faster. If you're hot, your heart beats faster. If you're having an infection, it beats faster. If the person is in pain, it beats faster. Medication. There are some medications that can cause a person to go tachycardic. There are some medications that can cause them to go bradycardic. Apical pulse is obtained by using the stethoscope directly over the heart. So apical pulse is the one that when you see the doctor in movies or if you go to the clinic to see the doctor uses that instrument that they put in your ear and they take the base of it and put it right around your chest at the level of your nipple. That is called a stethoscope, and they are listening to the apical pulse. So apical pulse is directly over your heart. Apical pulse can be felt on the left chest below the nipple. This is the diagram for the various pulse sites. I'm just gonna go over this right here. This is like how you do the apical pulse. Remember, the very first thing for any procedure, you want to start by identifying yourself. So you go to the resident. If you have to do like an apical pulse, you go to the resident, you identify yourself, you tell who you are, you talk about your title, you say what, you confirm that this is the right resident. You wash your hands. You explain the procedure to the resident. Speak slowly, and directly. Maintain face-to-face contact whenever possible. Provide the residents privacy with curtain, screen, or you close the door. Before using the stethoscope, wipe the diaphragm. The diaphragm is like the base part of the stethoscope. Wipe the diaphragm. You wipe the earpiece, the one that goes in your ear. You use alcohol wipes. Fit the earpiece of the stethoscope snugly into your ears. Place the flat metal diaphragm on the left side of the chest, below the nipple, and listen for the heartbeat. Use the second hand of your watch to count the heartbeats. Remember, I explained that when you're counting heartbeat and respiration, you are trying to get the numbers within a minute. So it's advisable that when you work in healthcare, buy a watch that has like a minute and a second hand. So if you want to count respiration, you can be looking at your hand and looking at the seconds, and you're counting the respiration. So use the second hand of your watch, count the heartbeats for 1 minute. Each lub-dub sound you hear is counted as one. So when you listen to the heart, if you put a stethoscope and listen to the heart, the sound you hear is lub, 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 lub. And this sound is counted as one. And this is because when your heart contracts to pump blood, when it squeezes together to pump blood, it produces a sound. And that is the lub sound. When it opens up, so the blood that is coming back and getting, that's the dub sound. So it's considered as one cycle. So lub, dub, lub, dub, lub, dub, lub, dub. That's how the heart beats. So when you are listening, don't get confused and think that those are different counts. It's counted as one. When you're done, wash your hands. Immediately, you go and chart it. So you go and put in a record, whether it's in a computer or it's in a book. Clean the earpiece, diaphragm of the stethoscope with alcohol wipes. Wash your hands. You want to put the call light where the resident can reach it. And if you notice any changes, if it's outside the baseline, report to the nurse. So this here is the same, it's a similar procedure you're going to do if you had to empty a resident's urine catheter, if you had to go check a resident's temperature. It's the same procedure. You always want to make sure after you're done, you clean up the equipment, because in the long-term care, they share those equipments with different residents. So after you're done, you want to clean it up. You want to always wash your hands before and after. Immediately after the procedure, you want to write it down and go chart it. Before you start, you always want to go in, greet the patient, explain who you are. Hey, my name is Sose Curly. I am the CNA working with you today. I am here to check your pulse. Can you tell me your name and date of birth? They tell you, you verify, make sure that it's the right person. Just like that. That's how you do with almost every single procedure. Respiration. Respiration is the process of taking in air into the lungs and exhaling the air out. The process of taking in air is called inspiration. You inspire air into your lungs when you breathe in. When you exhale, it's called expiration. You breathe out the air. When you breathe, the chest rises and falls. So if you ever get in a situation where a patient is having a medical emergency and you go, they are unconscious, you are looking at them, you're talking to them, they are not responding, you're calling out their name, they're not responding. You watch their chest closely. You see if it's rising and falling. If it's not rising and falling, you know they are not breathing. And the way you confirm that is you lower your head, you lower like your cheek to where their nose is, and feel if there's any air coming out. So the normal respiration for an adult is 12 to 20 breaths per minute. For children, it can go from 30 to 40. On the side here, I have some medical technologies. We had talked about anytime you see PNEA, I'm not sure how to pronounce that to you guys, but anytime you see PNEA, you know it's relating to breathing, it's relating to respiration. We also mentioned that this means difficulty. A in the front means absent. So you have apnea, which is absence of breathing. You have dyspnea, which is difficulty breathing. You have eupnea. Eupnea just means their breathing is normal. Orthopnea. Orthopnea is when a person has shortness of breath because they are laying down flat. I had mentioned that in the long-term care, you see residents that have diagnosis of COPD. COPD means chronic obstructive pulmonary disease. Pulmonary relating to the lung. So they have really bad lung disease. And this resident, when you lay them flat in bed, they start struggling to breathe. Like as you lay them flat, maybe you're trying to do a bed change or something, they start struggling to breathe. That's what's called orthopnea. So always pay attention and don't leave your residents laying flat because they have a hard time breathing or sometimes they cannot even breathe. You have tachypnea, tachy, rapid, it's going fast. So tachypnea, rapid respiration. Bradypnea, slow respiration. Then you have what they call Cheyne-Stokes respiration. So Cheyne-Stokes respiration, you have alternating periods of irregular respiration, rapid, shallow, along with periods of apnea. These terms are regular, irregular. They're very commonly used in medical field. I'm sure just with basic grammar, we all can understand what regular and irregular is. So if it's regular, it means that it's consistent. It's just going in a consistent pattern. It has to do with the pattern. When it's irregular, it means that the pattern is not consistent. So you can have tachy, it goes pop, 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 pop. And then after it goes brady, it goes pop, pop. So that's what it's meant by regular and irregular. So you can have irregular heartbeat, irregular respiration. When checking respirations, this is key, guys. When you're checking respiration on a patient, do it immediately after you've checked their pulse. So you count their pulse. When you're done, keep your finger like you're still checking the pulse, but you're now counting respiration. And the reason is because when people know that you're trying to count how they are breathing, it affects how they breathe. When people know that, when residents know that you're trying to count how many times they're breathing, it affects how they are breathing. They either hold their breath or they either breathe faster. So you want to just continue with the process without them knowing that you're counting their breath. Once you check the pulse, just keep your hand as if you're still trying to check the pulse. Leave your hand on their radial pulse, but now you start counting respiration. Any questions about that? Okay. Guidelines for measuring blood pressure. Blood pressure indicates how well the heart is working and measures in millimeters of mercury. So when you see blood pressure charting, you're always going to see mmHg. That is millimeters of mercury. That's just the abbreviation that they use. Just like how when you check a person's weight, you hear about how many pounds or how many kilograms. With blood pressure, it's millimeters per mercury. And this indicates how well your heart is working. So anatomically, you have your heart, the heart of the person. It's right here on the left side of the chest. The heart contracts. When it contracts, it squeezes blood out of the heart. It squeezes the blood, and the blood travels through your arteries, and it goes to your body. So it goes to your head, your brain, it goes down to your legs. That part where it contracts and the pressure of that blood, like the force with which the blood is going, that's what they measure as hypertension. It is felt in your arteries. That is called systolic blood pressure. The pressure when the heart contracts and it is forcing blood out, it is measured in your artery. It is called systolic blood pressure. When the heart relaxes, because what it does is the heart, this is how the heart is constantly. Has anybody ever seen a video? I don't, whether it's a real or fake video of a person's heart. It does this. It's like it's coming, it's squeezing and relaxing, squeezing and relaxing. That's really how the heart works. So that point of it relaxing, it's called diastolic. So systolic is when it is contracting and squeezing, and diastolic it's when it is relaxing. So you measure the pressure when they check somebody's blood pressure. They are checking both when it's contracting and they're checking when it is relaxing. That's why blood pressure is always written two numbers. You have the top number, you have the bottom number. The normal or the perfect top number, the perfect is 120, and for the bottom one is 80. That's like the perfect range. But remember, every person has their own baseline. You have the range, what the textbook will tell you, but people still have their own baseline. So always remember that. Blood pressure is measured by manual or digital sphygmomanometer. The device that you use to measure blood pressure is called a sphygmomanometer. The device that you use to listen to the heartbeat, or to listen to your bowels when you go to a doctor's office, that's called a stethoscope. A stethoscope you put in your ear, and then you.
Please repeat the first one.
Okay. So the one that you use to measure blood pressure, it's called a sphygmomanometer. If you can see my screen here, if you can see my screen here, I wrote it. It's called sphygmomanometer. I'll share the document after class so you guys can still read it and see it.
Thank you.
Yes. So it's called a sphygmomanometer. You use to measure the blood pressure. The device that you use to measure the temperature, it's called a thermometer. The device that you use to listen, it's called, to listen like to the heart, it's called a stethoscope. Something you're going to find out as you progress with your career for in healthcare, you're going to hear a lot of scope, a lot of devices that end with scope, devices that end with scope. The device that they will use to look at your ear, it's called an otoscope. When we're doing medical terminology yesterday, I said auto. When you hear auto, it refers to the ear. O-T-T-O. Auto is for the ear. An otoscope, that's what they use, and they examine your ear. Stethoscope, they listen to your heartbeat. Some of the things that can affect blood pressure, you have exercise. While you are exercising, if you are here running or you're jumping, will you have hypertension or hypotension? You can either say an answer or you can just text it. If a person is running or they are lifting weights and doing exercises, jumping, how will it affect their blood pressure? Would they be having hypertension or hypotension?
Hypertension.
Yes, hypertension. So that point where you're doing the exercise, your blood pressure goes up. However, the benefit of exercise is you train your heart on how to work. When you are not doing any exercise, your heart actually pumps way better. When you're resting, your blood pressure is now low. That's the benefit of exercise because you've trained your heart muscles. Whereas people that do not exercise, their heart is not trained. They have a lot of unhealthy things in them. That's how their blood pressure just keeps being high, high, high. I'm not saying that if you don't exercise, your blood pressure is bound to be high, but I'm just explaining like the benefits of exercise. Pain is the same thing. When a person is in pain and they're complaining, oh, my head, their blood pressure goes up. There are some medications that when the people take, it causes blood pressure to go up. Some medications will cause the blood pressure to go down. Alcohol, tobacco, those things, they affect your blood pressure. Obesity, people that are obese, they tend to have high blood pressure because their blood vessels. So just a little information, your blood vessels, like your veins and your arteries, they are just like tubes. It's just like a pen that you're having, Jenny. That pen has a hole inside. When you have bad diabetes, or if a resident has bad diabetes or they are eating bad cholesterol food, what happens is that cholesterol goes inside your vessel, your blood vessel, which is like that tip of your pen. It starts getting stuck in the walls of that tube. It's getting stuck in it. And now the hole was like this. It starts getting narrow because there's a lot of things that has been getting stuck around. It starts getting narrow. And the logical thing is when the hole is smaller, the pressure is more. Same thing with water. That's why the water pipes that they connect water inside your house, they are smaller pipes. If they were bigger pipes, the pressure would be so low that it cannot pump the water. So when they tell, go ahead.
You've said when the hole becomes tiny, that the things that is making the hole to become the tube to become tiny. What are those things that is making the tube to become tiny?
So cholesterol is a big one. When you have bad cholesterol in your body, which they call it low density cholesterol, LDH, cholesterol will form what they call plaques. It will form plaques inside your blood vessels. So the plaques now will start like attaching in the walls in your blood vessels. And when that happens, the size of the tube or your blood vessels, it reduces. And when it reduces, the pressure that your blood has to go through becomes so high, and that becomes a problem. Another disadvantage of that is if that plaque, those particles, at some point they could break. The particles can break in the vessel. As it breaks, something I want you to understand is you see like the water system is the same thing. When the blood vessels around your heart, they are bigger. As they are going out in your body, they are smaller. So let me just show you guys a little example here. Okay, so look at this diagram. If you see, your heart is right here, and the blood vessels that are closer to your heart, they are bigger. As they keep moving down and going down, or they are moving towards your arm, they are getting smaller and smaller. The size is reducing. So another disadvantage is when that plate is so much in your blood vessel, it breaks, it can get stuck in a smaller part of that blood vessel. That's why you see people all of a sudden, you hear that they're having a DVT, they're having like a thrombus. It means that there's a blockage in a blood vessel on their leg, and their leg gets swollen, and it's so painful because there's something like a plague that has come and blocked the tube, and now it cannot go. Just like how they tell you, don't flush wipes in your toilet or don't use paper towel because it can go and it goes and block the tube and water cannot go through. So it's the same thing with your blood vessels. So the key is always to try your best to make healthy choices. It's not easy, but it's always worth it. All right, let's get back to what we're saying here. Nursing assistant might be asked to do orthostatic blood pressure. So there is something called orthostatic blood pressure. They usually will recommend this for people that are dehydrated. So with orthostatic blood pressure, it means that you check the person's blood pressure while they are laying down. So while they are laying supine. Do we remember supine position from yesterday?
Yes.
Okay. So you check a person's blood pressure while they are laying supine. You have them sit up in a like a Fowler's position or a semi-Fowler or a high Fowler's position. You have them sit up for like 2 or 3 minutes. They sit up and they wait. You check their blood pressure again. After that, you have them stand up and wait for like 2 minutes or 3 minutes. You check their blood pressure again. That's called orthostatic blood pressure. It means you're checking the blood pressure at different positions. And that's how you can see somebody that is, people that are dehydrated will always tell you, I'm so dizzy, I'm so dizzy. It's because they don't have enough fluids in them. Once they stand up, their blood pressure drops because they don't have enough fluid. So when you stand up, you don't have enough. There's not enough for your heart to pump all over to your head, to the rest of your body. So when it doesn't have enough, your blood pressure drops. And your brain can tell, because remember, your brain always have the need for oxygenated blood, like high levels of blood. Once they don't get enough, people start feeling funky. They start feeling dizzy. They start feeling confused. So when people that need orthostatic blood pressure or people that are dehydrated, always try to walk them and have them sit down or lay down. It's very important. Any questions how to do orthostatic blood pressure? Any questions on how to do orthostatic blood pressure?
Orthostatic blood pressure.
Okay.
No.
So I would like for you guys to remember to also write down like the steps on how to measure blood pressure. The key things I want you to remember is anytime you're going to do any procedure, whether you want to measure blood pressure, you want to check pulse, you want to go do something like drain out a catheter, it always starts with you going to the resident, introducing yourself, tell them what you're going to do, identify the resident, like make sure that this is John. And a common way is, can you tell me your name and your date of birth? And they tell you. Before you start the actual procedure, wash your hands. Once you're done, you wash your hands and you chat immediately what the reading was. You chat it. If it's something that you need to go tell the nurse because it's abnormal, you go and tell the nurse immediately. Provide privacy when you're doing any of these procedures. If they're sharing a room, you want to use the privacy curtains. If they don't share a room, close the door. You will always have other residents that will be asking, hey, is John okay? What is John's blood pressure? You cannot tell if this person is having a high blood pressure or a low blood pressure. You cannot tell another resident. You are not supposed to. That's a violation of HIPAA. So if a resident wants to share their personal information, that's fine, but do not be the one sharing it. You could get in trouble for that. Okay.
I have a question.
Go ahead.
There's high blood pressure and there's low blood pressure. How do you know you have low blood pressure?
So I had shared in this let's see here. Okay. So there is a little slide up here. It's okay. It's okay. There's a little slide up here. And on here, we talk about the normal ranges for blood pressure. So the perfect blood pressure is 120/80. That's like the perfect blood pressure.
Mm-hmm.
However, anything between 90 to 119 for systolic. Systolic, that is when the heart is contracting, when the heart is squeezing blood out. Because blood pressure is always in two parts. You have systolic and you have diastolic.
Diastolic.
Yes. So then anything 90 to 119 is normal for systolic. And anything 60 to 79 is normal for diastolic. So if anything 90 to 119 is normal for systolic, it means that less than 90 is low for systolic. Does that make sense?
Yes. Thank you.
Same thing on the other hand, if for diastolic, 60 to 79 is normal, anything below 60 is low. So anytime you have any concerns with the numbers, just report it to the nurse, because sometimes the diastolic number, the lower number, can be extremely low while the top number is normal, and vice versa. So always refer to the patient's baseline, which what I do is after I check vitals, if I see anything looking funny, I always go back to the patient's record and see, and that is just because I'm a nurse, and I see all what their baseline has been. If the reading that I have is within their baseline, even if it looks low, I'll just be like, okay, I can just keep monitoring. But if you don't have the luxury of being able to go and review their baseline and compare it, just always report it to the nurse. And then I also mentioned hypertensive crisis. This is when you have a systolic number, the top number, if it is above 180, in fact, 180 and above for the systolic. If you need to take an Uber, take an Uber. If you need to take a jet, take the jet and go tell the nurse, because that's very crucial. That is how people start getting strokes. Because that will cause, that can cause the blood vessel in the brain to rupture and people can have stroke. So it's important. Same thing if the diastolic is above 120, that's a hypertensive crisis. That becomes a medical emergency. So people like that, sometimes they need to go to the emergency room through an ambulance so they can bring down their blood pressure. Okay, and then we have the pulse oximeter and pain assessment. So pulse oximeter is that little device that they put on the finger. For the purposes of your class and things like examination, you want to know how to count the pulse. But I'm pretty sure when you start working in the facility, you probably will not be doing the actual counting of the pulse, because pulse oximeter, that device, when you put on the finger, it tells you the patient's oxygen level and it tells you their heart rate or their pulse. Does that make sense? It's a, do you guys, is anybody here familiar with what the pulse oximeter is? It looks like this. It's a device like this. Put it on your finger, it will tell you the oxygen level and the heart rate. So if you look at this one right here, you can see that the oxygen level is 98% and the heart rate is 78. Any oxygen level above 90 is usually okay for residents, anything above 90. And that is because most of them, they already have chronic lung diseases. So when it's above 90, it's okay. But if it's less than 90, that becomes a big problem. Same thing with the heart rate. You already know the normal level is between 60 and 100. So this 78 here, it's okay. But that's what a pulse oximeter looks like. Pain is a very subjective thing. When you work in a long-term care and a resident tells you that I'm in pain, when you work in healthcare as a whole, always take what they tell you to be true. Don't try to argue or whatever. Take it as it is true, and then you go report it. Pain is not a normal thing when somebody gets old. That's a misconception or a stereotype. When people get old, their body don't just start to hurt as that's a normal thing. No, that is not normal. When someone tells you they have pain, you want to ask them where the pain is. When did your pain start? Does the pain come and go? You ask them to rate the pain. Rating the pain is a common practice, but it varies on the facility. You want to know how to rate the pain for people that cannot talk. So for people that can talk and tell you well, you ask them, on a scale of 1 to 10, how bad is your pain? On a scale of 1 to 10, where 10 is like unbearable pain that you're just like, whoa, you're just screaming. That's unbearable. And 1 is just like, eh. So you ask them so they can give you a number. But sometimes the residents cannot talk and you are looking at them, they're in pain. You go off of their other kinds of skills, which looks like, if you've ever been to like an ER, you see in the ER, you see like a bunch of faces, from smiley faces to twisting faces to grimacing. That's how you can also assess to see how much pain they are in. But always report to the nurse. Common signs of pain will include abnormality in their vital signs. So you can tell somebody's in pain by how high their heart rate is. If somebody is like being all, trying to hold themselves together, or they're twisting their face and they're telling you they're in pain, you can see how high their vital signs is. People sweat when they're in pain. Some people grind their teeth. Nausea, vomiting. Nausea is the feeling of you want to throw up. That's what is called nausea. So if you hear nausea, it's that feeling where somebody is like, I feel like I'm going to throw up. I feel like I'm going to vomit. That's nausea. Another way to know if somebody is in pain is they are pacing, they are rocking themselves back and forth. Sometimes they cannot walk well. If somebody is complaining of pain and then they are trying to walk, you can see how they're limping or they're crying. It's all different ways that you could notice if somebody is in pain. You want to report complaints of pain to the nurse immediately. Gently reposition the body in proper alignment. Use pillows for support. Assist in frequent changing of position if the resident desires it. So, you know, a lot of the residents in the long-term care, they cannot move as well. Like their movement is not as great as me and you. So sometimes the pain is coming from the way they are sitting. If you notice that, help them, move them, change their position, rub their backs. You could do like a warm bath. You could take them and go give them a warm bath, or you could use like warm compress. The pain could be from they haven't had a bowel movement, or they haven't been able to urinate and they are having pain. You want to check all of those things and help them so that they can urinate or excrete. You can try to encourage them to do like deep breathing. Sometimes you just need to walk them around and ambulate with them, and it relieves the pain. So it just varies. Make sure you use all those resources. IV. IV stands for intravenous therapy. So at the beginning of class, Raymond had some questions about IV, and we're talking about IV. So IV stands for intravenous therapy. The process of inserting an IV is a sterile procedure. So you don't do as the nursing assistant, you do not do IV. You don't insert IV. These IVs, it looks something like, let me put it here. So this is an example of what an IV looks like. It goes into your vein, and they use this typically for medications. So an IV looks like that. It goes into your vein, and they can pass antibiotics and stuff. So as a CNA, you will see residents that have IVs. It is done by inserting a needle or a tube into the vein. This is used for medication, nutrition, or fluid administration. So there are some people that they cannot eat, and they can only get their nutrition by IV. So they will literally put those IV tubes into their vein and then put in like their protein, their fat, they put in all those nutrients that they need straight into their vein. People that had dehydrated, we talked about dehydration, where people are complaining, they're feeling dizzy, they're tired. If the doctor determines that this person is dehydrated, they might need to give them IV fluids. They put the IV line in their hand, connect some normal saline or lactated ringers, whatever fluid is appropriate. They connect some IV fluids and give them hydration. Typically, people will have IVs in their hand for like 24, 48 hours, and they take it. But there are some people that have chronic conditions that they need to have an IV for as long as possible or permanently. They cannot put those little IVs in the hand, because the little IVs that goes in the hand, it's just a very little tube. So you see this right here. This is what they call a PICC line. This is not just, so this is what they call a PICC line. It's a form of IV. You have the regular IV. Let me pull a picture of the regular IV. That will make more sense when I explain. Okay, so this is an example of a regular IV catheter. You see how short it is? So this is an example of a regular IV catheter. It is short. It just goes inside the vein in your hand. It doesn't go long. That's short. But with other IVs, like a PICC line or a port, you have an IV port, or you have a PICC line. These ones are very long tubes, extremely long tubes. And it goes to the point where it reaches your heart. So these will be a sterile procedure. So a permanent IV is called an IV port.
Ali, can I have a cigarette?
The nursing assistant should document observations and the care they provide. You should not do any of the following when caring for a resident who has an IV line. So when a resident has an IV line, do not measure blood pressure on the arm that has the IV line. Do not get the IV site wet. Do not pull or catch the tubing on anything such as clothing. Do not leave the tubing kinked. So talking about tubing kinked is like the tubing for the IV, don't bend it, because if it bends, fluid will not be able to go through. So don't bend it. Don't lower the bag lower than the level of the IV site. So if you have a resident that is having...
It's open now.
Raymond, can you please mute your microphone? Okay. So if you have a resident that has an IV, make sure that you don't lower the IV lower than the point where the IV is in their hand. So they'll have like a bag that's hung up. Maybe it's just fluid going in, or it's an antibiotic. Don't drop that bag lower than their hand. Do not get the area of the IV wet. Don't touch the clamp. You have a clamp on the IV line where you could block the infusion from going in or not. Don't mess with all of that. Don't disconnect the IV pump. If you're taking care of a patient that have an IV, you want to report to the nurse. If you discover that the tubing is disconnected, you report to the nurse. If the dressing around the IV site, because the IV, there was going to be like a dressing that holds the IV in place. If you notice that the dressing becomes loose, let the nurse know. If you see that there is erythema, does anybody remember erythema? Redness, it's redness. If you see that there is redness around the area, you want to report to the nurse, because it could be a sign of infection. If you realize that this area around it is swollen, you want to report to the nurse. So anything you observe with the IV that is abnormal, report it immediately, because there could be an infection, it could be an infiltration, that it might be that the tubing is out of the vein. So report anything abnormal that you notice. If the resident says that the IV line is hurting, report it. Any questions about IV? Any questions about IV therapy? Okay. Oxygen therapy. This is the administration of oxygen to increase oxygen supply to the lungs. So your lungs are the primary organ that takes in oxygen from the outside. When it goes into your lungs, from your lungs, it goes inside your bloodstream. Your body needs blood that has oxygen in it. If any part of your body does not have oxygenated blood, it will start to hurt. Like you will feel pain. That's why if you cut supply in your hand right now, whether it's from holding your wrist or you tie it with a piece of, plastic or rubber, after some time, that extremity, your hand, your fingers, they start to feel numb, they start to hurt, and it could cause serious damage. So your lungs always need oxygen. And When you check a person's oxygen level, like we had talked about with the pulse oximeter, if it's at a lower level, you know that this person is not getting enough oxygen. So the doctors will prescribe oxygen for a patient. Oxygen may be stored in tanks. When you work in a long-term care, some long-term cares, they have oxygen tanks in the basement or in a specific room. And those are big tanks. And as a nursing assistant, they have smaller tanks where you have to go and fill up. So you take the smaller tanks, go into the oxygen room, fill up the oxygen in the smaller tank, and bring it to the resident. Beside that, you also can have what they call oxygen concentrator. Oxygen concentrators is just another machine itself that you plug it into the current and it produces oxygen. The oxygen concentrator will not store the oxygen. It just keeps producing the oxygen, and then you can connect the tube and put it in the resident's nose. Residents can receive oxygen via a nasal cannula or a face mask. What do you understand by nasal?
Through nose.
Yes. So you can get the oxygen through some little tubes. Let me see if I have a picture here. No, I don't have a picture. So the oxygen can be through a little tubes called a nasal cannula. Here's a sample of nasal cannula. So right here, you see it? It goes, there's like a tube that goes into the nose. And you can get your oxygen like that. Or you can get it through what they call the face mask. This is a face mask right here. You just put the mask and the oxygen goes in. The nurse will tell you which one is appropriate for the resident. Residents who need oxygen regularly or at all times, people that need it regularly, they use the nasal cannula. Residents who do not need the oxygen all the time, maybe just occasionally, those are the ones that usually use the face mask. It is very important to note that oxygen is a big fire hazard. So no smoking or any kind of fire around oxygen because it's a big fire hazard. Guidelines for oxygen delivery devices. Count and record. So before you start to set up a patient's oxygen, you have to count and record their pulse and respiration. So you count, you record their pulse and respiration and their oxygen level before you start giving them oxygen. That's the right thing to do. You want to check how much oxygen is flowing through the tube. So typically it's being measured. It's going to have a setting on the concentrator or on the tank, and they can say 1 liter, 1.5 liter, 2 liters. You just adjust the setting, and then the machine will deliver the amount of oxygen that is needed. Oxygen is very dry, so sometimes you need humidifier. You need like water, humidifying water attached to the oxygen concentrator so that it can humidify the air before it goes into the patient's nose. If not, it's going to be so dry in their nose and cause a lot of irritation. You have to change the nasal cannula just depending on what the facility protocol is. Sometimes they say every week, every 2 weeks, it varies. Make sure the oxygen tank is secured. Okay, let's go to nutrition and hydration. Nutrition is how the body uses food to maintain its health. A well-balanced diet in the elderly helps maintain their muscle, their skin, their wound healing, and prevent pressure injuries. Water is the most essential nutrient for life. So without water, a person can only live for like a few days and they'll die. But without food, you can survive a little longer. So it's always a good idea to encourage your patients to drink. Carbohydrates, that's another source of nutrient. Carbohydrates, they supply the body with energy. Sources of examples of carbohydrate, you have bread, cereal, rice, potatoes, pasta. Those are all carbohydrates. Proteins. Proteins are really essential for tissue growth, like wounds. And because some residents in the long-term care, they have a hard time eating. Their eating is so bad that they will actually prescribe them protein supplements, like liquid protein. And a lot of times with residents that have like wounds that cannot repair because they are not eating enough protein to repair their skin injuries. So they'll prescribe them like liquid protein. So proteins are essential for tissue growth and repair. Sources of protein include seafood, poultry, meat, eggs, milk, cheese, dried beans, and nuts. So this picture right here on the left, on the right-hand side, this is a recommendation by the USDA, the U.S. Department of Agriculture. They developed this plate to say that this is what a healthy plate should look like. You should have fruits, vegetables, protein, grains, and some dairy. So this is what a healthy plate should look like. Another source of nutrient is fats. Fats help the body store energy. That is really where your excess energy is stored. So in a long-term care, residents that are actually overweight or obese, that extra fat helps them, especially the ones that are not eating, because their body starts to break down that fat and use as energy. Whereas the ones that are already very frail, they don't have any fat in their body, they suffer. So fat is a store of energy. Sources of fat include beef, pork, dairy products. Vitamins are also needed for body function, and vitamins can be fat soluble or water soluble. Fat soluble means that the vitamins are stored in your fat tissues. Examples of those are vitamin A, D, E, and K. So fat soluble vitamins means that they are stored in your fatty tissue, while water soluble vitamins means that they are more in the water in your body and they get excreted when you go to pee. It goes out. Minerals help build your bone and make hormones. Examples of minerals are zinc, iron, calcium, and magnesium. Nutritional problems of the elderly. Loneliness. That's one of the problems. So basically what this is trying to say is people that are lonely or residents that are lonely, they have a hard time eating. So always try your best as a nursing assistant to encourage them to include them in things, because when they are included with their peers, they do better. They are much more lively. They want to eat. But if they are alone, they don't like eating. So loneliness is a problem. There are illnesses that affect the ability to chew and swallow. Example, stroke. They could also be like weakness from their arms and their hands due to paralysis. So when people have stroke, sometimes they paralyze on one side, and it makes it hard for them to hold their tray or to hold their spoon and things like that. So those are some of the common problems that they face. They cannot use their hands very well. Nausea. Nausea, as I mentioned earlier, is that feeling that you feel like you want to vomit, you want to throw up. People that have nausea and people that are vomiting, they don't like to eat. They don't like to eat. Slow metabolism, reduced activity and exercise affect appetite. When you exercise, it helps with digestion. People that just eat and lay, which happens a lot with in the long-term care, when you just eat and you just lay down, it affects your digestion. You get constipated, and when you're constipated, you don't feel like eating. Because of disease condition, some people in the long-term care, they have a decrease in their sense of smell or their sense of taste. And when you cannot smell food or taste it well, it's only normal that you will not enjoy eating the food. Low saliva production. A lot of residents in the long-term care, they have dry mouth. Their mouth is almost always dry. That affects their eating because it makes it hard for them to chew their food and make it soft and digested. Pain medication. A lot of residents in the long-term care, they have chronic pain from injuries, from degenerative diseases, and they take pain medication. A good example is oxycodone. Oxycodone causes a lot of constipation. So when these residents, they take medications for pain, they get constipated. When they're constipated, they don't want to eat. We talked about dentures earlier. Always do your best before you take your residents to go for their meals. Check their care plan. If they use dentures, you want to make sure that the dentures are clean and you have them in their mouth, because if they don't have it, they're not going to be able to eat. Sometimes they lose weight. The residents, they lose weight and their dentures do not fit. It's becomes so loose in the mouth that they smile, it falls off. You want to know all those things and report, so adjustments can be made. Poor hygiene. Try to clean their dentures before they go to bed. You always want to make sure that it's nice and clean. When it's not clean, they will not be able to eat properly. All right, I think we should take a 10 minutes break, and then we're gonna be back by 8:15. Let's take a 10-minute break. All right, my people.
Okay.
All right. Okay. Let us continue. All right. Next thing we're talking about is weight loss. So unintended weight loss is a serious problem for the elderly. Always monitor and report weight loss to the nurse. In long-term care facilities, the routine is they do like weights at least once a week on every resident. Sometimes the doctors will order daily weights. You want to always make sure that you check those weights at the same time every day, which is when they get up from bed before they start eating and drinking. That's when you should check their weights. So tell the nurse if the resident is having trouble using like their utensils, their knives, their spoons. You want to report that to the nurse. Record their meal intake and their snacks. So after residents eat, you want to make sure that you know how much of their food they ate and you document it. Provide oral care before and after meal. So these are all the things that you're doing in order to prevent the residents from losing weight. If a resident has a loss of appetite and seems sad, talk to them. Ask them about what's happening, why they're not eating. Report to the nurse if the resident needs help with eating or drinking. So we had talked earlier about after situations like a stroke, when a resident have a medical condition like a stroke, they could get paralyzed. It can be difficult for them to use their hands in holding their utensils or holding their cups. If you notice suddenly your resident cannot hold their cup to drink or they cannot hold their spoon, report it so that they could figure out if they need special equipments. Residents that eat less than 75% of their meal, report it. And this is going to vary from facility to facility. Resident house pain in their mouth, report it. Residents' dentures do not fit properly. Again, when residents lose weight, a lot of times their dentures stop fitting properly in their mouth. And it becomes so loose that sometimes they will laugh or cough and the dentures comes out flying. So when you notice that the dentures don't fit well, you want to make sure that you report that to the nurse. Residents that choke and cough while they're eating. This is also a big, it's a really health hazard. You want to report that because they could end up aspirating. Residents that are having crying spells, sad, or they're withdrawn from others. They might have other issues that's going on. You want to report that. Report observations and warning signs to the nurse. Food should look, taste, and smell good, particularly since the resident may have a poor sense of smell. So this is just the right thing to do as the nurse that's bringing the food to the resident or even the kitchen staff. You want the food to look good. You want the food to look good on the plate. That stimulates appetite. It encourages the resident to want to eat. Another key thing is always be engaged with your residents. No matter whatever thing that you're doing with the residents, engage with them. So if you're assisting with feeding, if you're assisting with bathing, shower, dressing them up, don't just be working like a robot and just be doing what you're doing. Talk to them, ask them how their day is going, just converse with them. It helps a lot. Respect the residents if they don't want to eat something, like honor their choices. If they want to eat this or if they don't want to eat that, respect it. Give them positive compliments when they do tasks for themselves. Make sure you give them positive compliments. Help your residents who have trouble feeding themselves. Help them with seasoning their food according to their preferences. Allow enough time for the residents to finish eating. Time management is a really big thing in healthcare, especially in long-term care. It's really key to manage your time and allocate it so your residents can get the help that they need. And that comes in play during meal times. You want to allow time for residents that need to eat. You want to allow time for yourself to help those that need help eating so that they can also eat. In the long-term care, you're going to see residents that have been prescribed thickened liquids. So some residents will be prescribed thickened liquids and soft foods. These will be given to residents that have dysphagia. We talked about dysphagia as being difficulty with, can somebody complete that for me? What is dysphagia? Dysphagia is difficulty swallowing. So when residents have difficulty swallowing, they will prescribe them thickened liquids and they will try to make their food soft. Some of the foodstuff that will that will pass for thickened liquids are like milkshake, sherbet. Sherbet is like an ice cream. It's like a little ice cream in a cup. Sherbet, cream soups. Those are some of the things that you give to patients with dysphagia. Their care plan will always tell you all these details. Their meal card will also always tell you these details. So you want to pay attention to what their meal card says, to what their care plan says. When the digestive system of a patient is not functioning properly, the digestive system, it starts from the mouth right down to the rectum. So if that patient is having issues with the digestive system that is not working, then they do what they call parenteral nutrition. Parenteral nutrition, or TPN, which is total parenteral nutrition. What this means basically is that they give them their nutrients or their nutrition through IV. They will put IVs in their body and give them their nutrition through IVs. You will also see residents with tube feeding. Tube feeding is indicated when a resident is unable to swallow. So if a resident has dysphagia, but they can digest food. If a resident is unable to swallow, but they can still digest their food. And you will see this with patients with stroke, patients that have cancer, and sometimes you have residents that outright refuse to eat. They just don't want to eat. They just don't feel like eating. When that happens, they end up getting tube feedings. An example of tube feeding is NG tube. NG tube stands for nasal gastric tube. What does the nasal stand for? What does it refer to? Can anybody help with that? Okay, I think I have one
What
answer.
nasal?
Yep, the
Nose.
nasal. Yes, the nasal is for the nose. What about the gastric?
Or esophagus or the
Stomach.
The stomach, yes. So the esophagus is still partly correct, but it's mainly nasal gastric. So it goes through your nose till it gets into your stomach, which is the gastric. So you will see people having nasal gastric tube, and it goes in the nose. There's a little attachment, that part of it that comes out of the nose where they can mix the food and just use a syringe and push it through the nose. You have what they call a PEG tube. The full meaning of PEG tube is percutaneous endoscopic gastrostomy. When we talk about ostomy, what do we understand by ostomy? Yesterday, we were doing some medical terminology. We talked about ostomy. So ostomy means there is a surgical hole on the body. There's a surgical opening on the body, surgical hole. That is ostomy. So gastrostomy, it means that there's a tube that opens to your gastric, to your stomach. So gastrostomy means they're gonna make, if this is the stomach, like when you look at a person, if this is their stomach right here, the wall, they're gonna make a tube from outside their body, make a hole and connect the gastric tube, and it goes inside their stomach. That's a PEG tube. It is very, very important. Okay, what position do you think is appropriate if you're giving a patient, if a patient is getting like a PEG tube, a tube that goes through the stomach and they're pushing food? What position should the patient have? Should they be supine? Should they be prone? Should they be in a Fowler's position?
Fowler's.
Yes, Fowler's. That's the correct one. They have to be in Fowler's when they are having a PEG tube. And the main reason is risk for aspiration. So aspiration is when food particles or liquid or fluids, instead of going through your esophagus and going into your stomach, it goes into your trachea or your windpipe and it goes into your lungs. So when patients are getting tube feeding, you want to make sure that they are sitting up, because if you don't sit them up, that fluid, because this tube feeding is always in the form of like thick liquid, it can climb up and start going into their lungs. And this can kill them, or it can cause really bad pneumonia. Anytime food particles or fluid go into the lungs, it has the potential of growing bacteria in there, and then it can cause pneumonia and they can die. So remember to always keep them up. So gastrectomy is surgical opening that goes into the stomach. Ostomy, opening. What about colostomy? Can somebody remember what colostomy is? Ostomy, what does ostomy refer to?
The cut of the colony. Cut of the colony.
Yes, colostomy involves part of the colon, but what does ostomy itself refer to?
Surgical opening.
Yes, ostomy just means a surgical opening. That's all ostomy means. Now, when you hear ostomy, it's a suffix that just means surgical opening. When you hear gastrostomy, that gastric is referring to the stomach. So it's just an opening. It's an opening that goes into the stomach. If you hear urostomy, urostomy is uro is referring to the bladder, and then that ostomy at the end, it means that it's an opening that they just make right where your bladder is. They will just burst a hole on the resident and connect a tube in there, and it just drains urine out of the bladder. Ileostomy, it means at the level of the small intestine, the ileum, they're just going to make a hole that leaves from the outside of your body, and it just goes into the small intestine, and stool, poop can come out of it. So These are some of the guidelines for tube feeding. Always wash your hands before you start assisting in any aspect of tube feeding. So as a nursing assistant, you're not typically going to be the one to give the tube feeding. But again, the nurse can always call you to come and assist, and they can tell you, direct you, like, I want you to do this. I want you to open this bag. I want you to, assist in putting the patient in a Fowler's position. So you wanna be there and help, but always remember everything starts with hand washing. You greet, you introduce yourself, you tell the resident what you're doing. Patients that cannot swallow, they will always have an order that says NPO. NPO. What does NPO mean? NPO is nothing by their mouth. So it's in Latin. It's in Latin, which says nothing per us. A lot of medical terminologies originate from Latin, because Latin was the most popular language back then. But yeah, NPO means they cannot have anything in their mouth. They cannot swallow anything. You shouldn't give them any water. You shouldn't give them any food. It's really important to pay attention when you see this NPO, because it typically means the patient has trouble. They cannot swallow. And when you put things in the mouth of people that cannot swallow, it ends up going into their lungs. And when things go in the lungs, that's grounds for pneumonia, and they can die, like, easily. So pay attention to that. Not only that, they can choke also. They can choke and literally die right there. The PEG tube feedings, nasogastric or PEG tube, they're usually inserted and removed by a doctor or a nurse. If it comes out, report immediately. A doctor will prescribe the type and amount of feeding. So when patients have tube feedings, they have a special prescription for what kind of food, liquid food, they're going to be using. A resident with feeding tube should always have the head of the bed elevated 30 degrees. That's a semi-Fowler's. However, during the feeding, the resident should remain in a sitting position with the head of the bed at least 45 degrees. When it says at least, it means that while you're feeding them, they can be totally upright, or they can at least be 45 degrees. So that's a Fowler's position. This helps prevent serious problems such as aspiration. Aspiration, again, is when food and fluid particles, instead of going through your esophagus and going into your stomach, it instead goes into your lungs. That can cause choking, that can cause pneumonia, and that can cause death. The elderly can develop pneumonia or die from improper positioning due to tube feeding. After the feeding, keep the resident up for as long as ordered, at least 30 minutes. As a rule of thumb, whenever residents eat, whether they have tube feeding or they just ate from the dining table, always try to keep them in a sitting position for like 30 minutes. The beds are designed in a way that you can actually have them be in that sitting position. You just need to use the bed control. So when a resident is on tube feeding and you notice that there is redness or drainage around the opening on the body where the tube is, because remember, these tubes go through their body. It goes through the body cavity. So for example, let's see here. Let's look for a PEG tube. So this is an example of a peg tube right here. Can you guys see it?
Yes.
So they literally make a surgical hole and they put the tube and it goes straight into their stomach. Now they will connect the tube, the feeding. It's usually hanging on the pole like an IV. They will connect it at the end of this tube right here. Same thing with their medications. So around this area here where the tube is in the body, if you notice that there is redness, there is rash, there is any kind of drainage, like pus is coming out of there, anything abnormal that you notice, report immediately to the nurse. Very important. If you notice the skin is cyanotic, what do we understand by cyanotic?
Ashes.
Cyanosis. It has to do with discoloration. So cyanosis, cyanotic, it means that the area around the skin, whether it's in the finger, the nose, or it's on the, in this case here, we're talking about the area around the peg tube. If you notice that it's turning blue purple, it means that it's not getting oxygenated blood. Anytime a part of the body is not getting oxygenated blood, it starts turning bluish purple. That is cyanosis. In dark-skinned people like me and you, it's really hard to tell. You can easily tell in the inside of their mouth, mucous membranes of the mouth or the mucous membranes of the eye. That's where you can tell the bluish purple. With light-skinned people or with white people, it's much more easier to tell. So whenever you notice that around the site of a peg tube insertion, report it to the nurse. Any questions about that? Okay. If the resident is reporting pain or nausea, feeling like they're about to throw up, report to the nurse. Typically, they will stop the feeding. If they are having vomiting, diarrhea, if their abdomen is swollen, always report it so that they can stop the feeding and have the resident take some time to recover. If you notice that the machine is beeping, there is a change in the resident's position, report it, adjust them to be in a better position so they don't choke. With feeding and with nutrition, always consider the fact that culture, ethnicity, education, and religion can affect what people eat. And that's just a normal thing. So when you know that, you tend to work with the residents so that they can get alternative. I know a common one is for people that are Muslims, they don't eat pork. So if you know that you have a resident that doesn't eat pork, you want to always check the meal cards. When they verify the meal card and make sure that the resident does not get pork, or if there are other substitutes that the resident could get, advocate. As a nursing assistant, it's your responsibility to always advocate so so that the residents get the best care that they can get. So again, consider the fact that culture, ethnicity, education, religion can affect diet when caring for your resident. Respect resident choices and make accommodations for alternative meals as allowed and provided by the facility. The dietary department should prepare meals and follow residents' cards. So Raymond, as we were talking earlier at the beginning of the class, these facilities, they always have dietary department or kitchen department. They are the ones that order the food. They are the ones that are responsible for storing the food, making sure that it is kept at healthy temperatures. They cook the food and then they serve the food. So as nursing assistant, you want to verify. Jacqueline, did you have a question? Okay. So as nursing assistant, you want to verify the meal cards to make sure that the resident is getting the appropriate food, and their choices are being respected. Nursing assistants must ensure diet cards matches the correct resident, name, restrictions, allergies, likes, and dislikes. Food allergies are also another big thing that you wanna know about your residents, because a resident could eat the wrong thing and have what they call anaphylaxis. That's the most severe form of a reaction. So with anaphylaxis, when people eat things that they are allergic to, anaphylaxis, their mouth swell, their face swell, and with all that swelling, their throat, inside their throat, it swells up and it shuts. So it shuts, it closes up like this. They cannot get air in, and people die from anaphylaxis. So you want to always make sure that patients that have allergies, they also have to check with the nurse to make sure that if this person has an allergy, they have EpiPen, which is an anti-allergy medication. So verify the name, verify the diet, verify their allergies, and this is usually on their diet cards. Residents who do not require a change in their diet will often eat a regular diet. So people that are normal, they don't have any problem with their swallowing, they don't have any problem chewing, they don't have any issues like that, they're just going to be having regular. People that cannot swallow, then they can start having tube feeding, or they can have some other kind of modified diet. Residents with certain illnesses or certain medications will have therapeutic, modified, or special diets and must be prescribed by a doctor. Pay attention to that, because you have residents that will tell you, I want this. They might see somebody with a mechanical soft or a thickened liquid, and they think it's the cool thing to have, and they start asking you to give them. You can only, or you are only allowed to give people that diets if it has been prescribed by the doctor. Don't, if anytime you start giving people things that has not been prescribed, it means you are taking the role of a prescriber, you're taking the role of a doctor, and you could get in trouble. Also, residents have the right to refuse. So you can see a resident that you know that this person will benefit from eating. They look so frail, they look so weak, dehydrated, and you try to help them eat, they refuse. You cannot force them. Even though it's for their own good, you cannot force them. You will get in trouble. You could lose your license for forcing somebody to eat. So offer them, talk to them, encourage them, but if they refuse, the best thing you can do is document. You go and document that you offer to them and they refuse. Some examples of restricted diets. It includes low sodium, fluid restriction, high potassium diet, low protein diet, low fat diet, low calorie, balanced diet, diabetic diet, low residue fiber diet, high fiber diet, vegetarian, gluten-free, vegan, liquid diet, soft diet or mechanical soft, puree diet. The most common ones that you are actually gonna deal with on regular basis, it's gonna be puree. With puree diet, they literally grind the food. So if we're having chicken and vegetables, let's say chicken and some peas and some spinach or broccoli, They will just grind the chicken and they'll also grind the vegetables. So it just looks like baby food, like the baby food that we have in little cups that they give to newborn. That's how puree diet looks like. You will see that a lot for a lot of residents that they don't have teeth or they cannot chew or they have problems with their chewing. They just give them puree diet. That's common. You have soft and mechanical soft. With these ones, the food is chopped off in small, tiny particles, and it makes it easier for the residents to be able to chew it and swallow it. That is mechanical soft. You will also see a liquid diet. For the liquid diet, it's usually before or after surgery. So they use the liquid diet just because when people go for surgical procedures, the doctors prefer that they don't have food inside their digestive system. Because when you have food in your digestive system and you're sedated, they give you sedation, there is a high risk with you laying there, turning around, the food can come up and go into your lungs. That leads to aspiration. So they do like liquid diet or they do like NPO so that these people don't have any food in their stomach that could come up and get aspirated into their lungs. So liquid diet is common. You also have diabetic diet. That's pretty common. In long-term care facilities, you frequently have diabetics. And with these diabetic diets, these residents, they take insulin. So the nurses will have you count their carbs, or the nurses themselves will count how much carbohydrate this person is eating. So on their meal cards, it's gonna say something like bread and chicken. The bread is 16 carbs. The chicken is 8 carbs. When they count all those carbs, the doctor is gonna prescribe for 8 carbs, give 1 unit of insulin. So it is really important to pay attention to those details so you can report to the nurse and the nurse will give them the appropriate amount of insulin that they need. People with diabetes, a lot of times in the long-term care facility, these people get artificial sweeteners. So they don't get the regular sugar that me and you will just pick up and eat. Because with diabetes, they don't get enough control of their sugar. So they use artificial sweeteners or low sugar stuff for them. So when someone is diabetic, always ask and see where the artificial sweeteners are kept so that you can use that instead of regular sugar. Fluid restriction. So on a normal healthy human, the amount of fluid that you are taking in, like the amount of water that you're drinking, if you are eating like a soup, whatever, the amount of fluids that get in should be the same amount that goes out. But people that have problems with their kidneys, and your kidney is the one that is responsible for making urine. People that have problems with their kidneys and people that have heart failure. Because with heart failure, your heart cannot pump enough blood to go to your kidneys. So those people, they tend to keep more water in their body. And as a result, the doctors will prescribe and be like, hey, this person can only drink 1 liter of water in a day. This person can only drink 2 liters of water in a day. Doesn't matter how much that resident is coming to you and telling you like, I want water, give me water. If they have already had that 2 liters in a day, don't give. Report to the nurse. Let the nurse make the decision. Because if you give more, you end up hurting the resident because they'll be keeping more water in their body and it causes them other problems. So fluid restriction is another one. Low sodium. Sodium is salt, and salt pulls water. Salt likes water. So people that, again, that have problems with their kidneys and their heart, they tend to keep water in their body. When you give them foods that are high in salt, it makes them keep even more water in their body. So that's why they'll prescribe low sodium for people, so that it reduces the amount of water that can be retained in their body. Any questions about any of those? Okay. So residents with dysphagia, difficulty swallowing, can be ordered to be on thickened liquids. And thickened liquids in a long-term care, there's always like different categories. You have what they call nectar thick. That's like, it's just a little bit thicker than regular consistency of fluids. So you have nectar thick. The kitchen will always provide with all the supplies. Some facilities, they just have little packets of the different kinds of thickener. So they'll have little packets of nectar thick, where you could just tear open the packet and pour it inside a cup of orange juice, and you just make the orange juice nectar thick orange juice. If it's honey thick consistency, you just tear the packet of honey thick, pour it in the glass, stir it, and you just made honey thick. So that's one option. Another option is the manufacturer of the orange juice, the facility will just have the kitchen department or the dietary buy juice that has already been nectar thick or has already been honey thick right from the manufacturer. And then that way it's easier to give to the resident. And then you also have pudding thick, which is like the thickest form. So this is being ordered depending on how serious is the dysphagia. Promoting socialization and healthy eating is an important part of the nursing assistant's job. Socialization, very important. Nursing assistants should offer feeding assistance as specified, when necessary and when needed. Remember, you always want to encourage the residents to do as much for themselves as possible. But if they need your assistance, help them. If they request it, if it's ordered, help them. Promote independence as much as possible. Again, when we talk about procedures, like procedure for feeding, procedure for emptying a catheter bag, procedure for checking vitals, the key thing to remember is almost all of those procedures is the same practice. You go to the residence room, you introduce yourself, you talk about your title, you confirm who the resident is, you tell them what you are in to do, you wash your hands, you use your equipment that need to be used. After you're done, you chart. After you're done, you wash your hands, you provide privacy, close the door, open the door, whichever one needs to be done. You wash your hands, you chart. Always chart. If it's feeding, you want to chart how much they ate. It's easy when I say this, but in a real practice, when you have those residents, it's not easy to just finish feeding one resident, you turn around and go chart. You come and feed another resident, you turn around and go chart. So to help yourself, have a piece of paper. When you sit on the dining table and you're feeding your residents, just have a piece of paper. A at 75%, B at 20%, Just like that. That's what you do. You document it so that when you're done feeding them, now you can go to the computer and go ahead and chat. But chatting is very important. In healthcare, it is considered that if you don't chat it, it means it did not happen. So you can be the #1 CNA in the world. You do everything for your residents. The moment you don't chat it, that you've done this care, it means you did not do it. If anything were to go wrong in the court of law, they're going to say you did not do it because you did not chat it. So chatting is very important. So this picture right here, these are some of the adaptive equipments and ways you could help your residents during meal times. The very first picture here, it's what they call the hand over hand approach. And this is used when a resident can help by lifting utensils. It improves and promote their independence. So if you have a resident that you're sitting with on the table, they have the strength, their hands are working such that they can pick up their utensils, but they lack that courage, they lack that interest. You can try the hand over hand. Just have them hold the spoon, you hold your hand, take your hand and put it in the food and be like, okay, grab some food, guide them to put it in their mouth. If you do that once, twice, sometimes they then continue eating by themselves. That's the hand over hand. You have some residents that they are legally blind. Being legally blind does not mean that you cannot see anything completely. So if you have a resident that is legally blind or completely blind, either or, you can set their tray or their plate and have them use what they call an imaginary clock. So when you look at a clock, you have 12 up, you have 6 down, you have 3 to the right, you have 9 on the left. So when you put their tray, you can tell them water is at 12 o'clock. Your knife is at 3 o'clock. Your spoon is at 9 o'clock. When you tell them that, even though they cannot see well, they already have a visual imagination of where the different utensils or their food is kept. That's a tip of helping them. On the other picture here, these are just special equipments. Depending on what the occupational therapy and the doctor have determined, these are just like special spoons, special cups. Sometimes you even have special plates that have been designed to help the resident eat better. Let's talk a little bit about dysphagia. We've been talking about dysphagia. Can somebody say what dysphagia is?
Difficulty in swallowing.
Yes. Can you say one of the things that can cause dysphagia? Stroke. When a person has a stroke, it can cause dysphagia. Remember, stroke has to do with your brain. Your brain is like the computer of your body. Your brain controls everything. Your brain and your spinal cord, they have centers in them where it controls how you breathe. It controls when you blink your eye. It controls when you touch something, a hot pot, and you pull out your hand. All of that is controlled by your brain. How you swallow is by your brain. So when you have a stroke, it's possible that the nerves in your neck that are responsible for swallow can be damaged. The person can also have like an injury, an accident, and they get paralyzed and they can't swallow. That could cause problem. Another one is cancer. Cancer can cause it. Cancer can cause a dysphagia. Parkinson's. Does anybody know what Parkinson's is? So Parkinson's is that disease. If you've ever seen a person that is kind of like shaky like this.
Shaking.
Well, I grew up in Indiana, in the Midwest, on a small farm in a small town.
So with Parkinson's, you see patients, they are like shaking. That can make it difficult for them to swallow. That's how Parkinson's affect person. They are always like having jerky movement. Their head is shaking. They stand and they're talking to you and they're shaking. That's how the disease affects them. That can cause difficulty with swallowing. So dysphagia is difficulty swallowing. A stroke or a cardiovascular accident can cause weakness or paralysis on one side of the body, and this can cause these people to have trouble swallowing and chewing their food. Other causes of dysphagia include cancer, Parkinson's, Alzheimer's, neck and nerve muscle tissue damage. So Alzheimer's is a disease of the brain. It affects the brain, and as people get older with Alzheimer's, it makes them forget. They just forget a lot of things. They will forget and forget to eat. That's how bad it is. Yes. Thanks, Sosie, for what you said. Yes. It's really difficult to watch some of those residents. You just try as much as you can to help them, but they get so forgetful that they forget that they need to eat. Some will forget their name. They'll forget who they are. They'll forget a lot of things. It becomes so difficult to care for those kind of residents. And those are some facilities will just have what you call a dementia unit for people that have become so forgetful and they're always confused. They have a unit where it's only those kind of residents are there. Not all facilities are designed like that. Some facilities, they just have everybody mixed in between. Okay. So some of the signs and symptoms of problems with swallowing. Can anybody just tell me, how can you tell if somebody is having difficulty swallowing? What are some of the things you can notice?
One team. Going to pick up Texas. Go back to everybody.
So when people are having trouble swallowing, you can tell just by looking at them how they are, struggling. They cannot chew. They are choking. They are coughing. You have saliva just dribbling down their mouth because they cannot control it. You have food residue inside the mouth or the cheeks after meal. So when you see people that have food in their mouth, this is another common thing you will find in long-term care facilities. You have residents that you're feeding them, you keep putting food in their mouth, they just keep opening their mouth and they're taking the food. And after like 3 minutes, you realize that the mouth is so full, drool is coming out, particles of food are falling out because they are not swallowing the food. That is called pocketing. So when people keep food in their mouth like that, in medical terms, they say pocketing. So pay attention for pocketing. That's a sign of people having trouble swallowing. Gargling during and after meals. Eating so slowly, avoiding eating, spitting out pieces of food. Swallowing several times per mouthful. So they put food in their mouth and you see they keep trying to swallow. They keep trying to swallow. Watering of the eyes when eating or drinking. Food or fluid coming up into the nose. Making visible efforts to swallow. Breathing rapidly. That is tachypnea. Breathing rapidly while they're trying to swallow. Difficulty chewing. If they've been having trouble swallowing their medication, then you know that this person is having trouble swallowing. Okay, I think we can call it quit for today. Any questions before we go? So one of the things that I really want you guys to do today is review. Just try to review. You can go through the slides. You're going to see at least one process or procedure on how to do something. So review like how to check temperatures, how to do feeding. It's a standard way for everything. It might just differ now because this is food going in the mouth, or that is a thermometer going in the mouth, but it's the same standard practices. Hand washing, introducing yourself. So review the different things that we've talked about today, how to check blood pressure, just review them. You can do your own Google search, okay? That's what I really want you guys to do today. Any questions?
Yeah, so I'd like to now most of the course today I wasn't really attentive because I'm at work, I'm busy doing stuff. So I don't know. How can I review the lessons for today? How can I get it?
Okay, so I am recording it. I'm gonna share it with you guys in the group. So I'm gonna share the link so you guys can watch all the classes that we've been going over. And then I also have this this document, what we went over class today. I've already shared it in the group. So if you open the group, you can see all these slides that we've been discussing from today. You can also read that. But guys, remember you cannot.
Thank you,
No.
sir.
Yeah, you're welcome. Remember, you cannot share this you cannot share the documentation or the lessons with anybody that is not in the class. You can't share it. Okay? Please don't do that. But yeah, I will try to share those links. And then you guys let me know if you're having trouble accessing them. You can just communicate inside the group. All right. All right, guys. You guys have a good night.
Good night.
Any other questions? All right. Good night to everybody.
Good night.
Good night.
All righty.